First of all, I'd like to thank Dr. Kerr for having me speak today, and I'd like to thank Dr. Pidcock as well, who spoke a couple of days ago, for giving me the opportunity to speak about spasticity, because he could have spoken about this himself, but he graciously allowed me the opportunity to do it. Now, I'm a rehab physician by training at Johns Hopkins and Sinai Hospital here in Baltimore. I'm also continuing my training in pediatric rehab. This is a good follow-up after Dr. Wegner's lecture, because our role as rehab physicians is essentially to improve your function. Everything that we've heard about the last couple of days about cures and trying to treat the illness early on is very important, but you guys have things to deal with today and tomorrow to try and get through your daily activities, which, of course, as Dr. Wegner has described, is a lot of work, and of course you folks already know that. So one of the biggest issues with dealing with spasticity, and I'll start off really quick by saying that I have good news and bad news. The bad news is I have about 20 minutes to try and talk about a topic that could easily be talked about for a couple of hours at least. But the good news is that in the breakout sessions this afternoon, I will be hosting the discussions on spasticity. So if there are more questions or concerns about spasticity, please come to those breakout sessions, and we can try and answer those questions for you. So briefly, the outline will be discussing first the definition, then the consequences of spasticity, setting treatment goals, and then I'm going to discuss some various options. I'm not going to be able to discuss all of the options, but I'll discuss a few of them and sort of the most common ones that we use as physicians. The definition of spasticity is a motor neuron disorder where there's velocity-dependent resistance to stretching the muscles. So if you pull on it really fast, really hard, it gets very tight very quickly, but some of those muscles can still be stretched out slowly with a prolonged stretch. And you can also get increased reflexes, which can lead to clonus, where your ankles bounce or your knees start shaking, and I'm sure some of you folks who have experienced those problems as well. Now, spasticity can lead to this long cascade of problems, decreases your functional abilities, leading to inactivity. You're sitting in wheelchairs for a long time, some of you, so you can get pressure ulcers on your backside, as well as folks who are wearing braces on their ankles or other parts. You can get skin breakdown because of that. Decreased activity leads to cardiovascular problems, clots in your legs, respiratory problems for folks who have higher level injuries and they don't move their respiratory muscles as well. They can lead to further decrease in strength and function. It sort of ends up being this cycle. You're not active, so things get tighter, you get sicker, and then you're less active, and it's just this sort of vicious cycle that happens. Also, of course, it can lead to social isolation because you're not out and about as much. It's more difficult to get out and about. Bowel and bladder problems, which can, of course, contribute to social isolation. You get decreased bone density because you're not up and walking as much. You're not standing on your limbs, so you lose bone density a little bit more quickly. And from the spasticity and the tightness of the muscles, your joints can get stuck in these positions, and then what can happen is the muscles actually will change their anatomy and become permanently shortened. And then, again, all of these things together can just lead to further decreasing in your function. Now, of course, the impact of spastic disorders, as many of you probably know, it decreases your ability to get around. It makes it more difficult to take care of yourself, clean yourself. It can interfere with your sleep. If you're having spasms at night, you can't get into a comfortable position. It can lead to the contractures and then disfigurement of your joints. Your arms or legs can get stuck in positions, and it can decrease your self-esteem because of all of the things that Dr. Wegner discussed, and it can affect your mood and also your sexual function. Now, the effects of transverse myelitis on your motor function, other than the weakness that's associated with having a spinal cord injury, there's also changes in the patterns of the muscles. So there can become a muscle imbalance, whereas normally you can focally move one muscle. What happens frequently with these injuries is that you try and lift your foot up, but what happens is you also extend your knee and flex your hip, and you get into these patterns of movement, and you can't selectively control which muscles are moving. You also have the muscle weakness, so of course strength is not there, And as I mentioned before, you can get the permanent changes in the muscle length and the progressive deformities in the joints. And of course, these progressive deformities in the joints can lead to advancing arthritis, as well as increasing your pain, which can increase spasticity as well. So once again, you get into that cycle. Now, for the physicians, the technical questions that we examine when thinking about treating spasticity are: how are these overactive muscles and contractures impairing your function, and are they preventing full stretch and range of motion at the joint, and which muscles are contributing to these issues, and what can the performance of other muscles be improved by decreasing the co-contraction, or these patterns of movement that I was discussing, and allow more focal movements of muscles, so it makes it more efficient for you to try and use your extremities. Now, does spasticity need to be treated? Not always. There's good spasticity, such as the tightness in your legs, that may allow you to walk, whereas without that tone, with the weakness, you wouldn't be able to. So in that case, you have to be careful not to overtreat the spasticity. So is it interfering with function, positioning? Can you not get in a comfortable position in a wheelchair or in your bed? And are you uncomfortable? And how difficult is it for you to care for yourself? Things that we all take for granted, not having disabilities, such as just going to the bathroom and being able to clean yourself afterwards, is a whole issue for some of the folks that have the more severe disabilities. So as I mentioned, is the spasticity useful or not useful? Does it help you transfer from your chair to a bed? Does it help you walk? And is the treatment expected to provide meaningful improvement? So do you want to take a medication or get a shot if it's not really going to do anything for you, meaningfully improving your function? Now, the possible treatment goals. Now, treating spasticity doesn't always have to be specifically with the goal of improving your function. It can be to decrease the burden of care on yourself or caregivers, making their job easier. And it can also just be to improve how the limb looks, if that's a concern for you. But of course, we hope that it's going to improve your ability to do things for yourself, decrease the amount of energy that it requires to do these things for yourself, decrease your spasm frequency, which can be painful, and then also for folks who are wearing orthotic devices, improve the fitting of those devices, the tolerance of those devices, which can also hopefully help you improve your function, as well as the other things that are listed in your handout. Now, the keys to successful intervention for treating spasticity, and this is a very important issue: define the patient's goals. Now, all of the physicians and therapists, we all have sort of an image in our minds of what we'd like to be able to do for you, but it's very important for you to let us know what you're hoping to get out of it. For adults, that's not as difficult as it is for children. And I'll tell you a quick story that was told to me by a pediatric neurologist, Tom Crawford at Hopkins, who works with muscular dystrophy. He had been, and muscular dystrophy being a progressive disease, kids can walk early on and then lose the ability to walk later on. And there was a young teenager who was starting to lose the ability to walk. And they spent, during the summer, the first half of the summer, very aggressively treating this kid to try and keep them walking. And therapy every day, and bracing, and lots of work. And about halfway through the summer, this kid finally said to the parents and to Dr. Crawford, "Hey, you know, can you just give me my wheelchair and let me go play with my friends, please?" So it's very important to recognize what the patients and what your children are hoping to get from these therapies. So what can we do to make their lives better the way they want to, not the way we envision it? So we also have to define the potential, which we do with you, so that we're not trying to bite off more than we can chew with these treatments. And we want to be able to define the functional problems so that we're treating appropriately. And we want to be able to understand the limitations of the treatment option. So we don't want to do things that aren't going to work for you. Choices of therapies. Now, this is actually a continuum. It's not an either-or. So you can be on oral medications, which I will discuss. You can also get injections, and you can also have a baclofen pump, which I will all discuss a little bit later. These things can build on top of one another. So it's not as if one fails, you move on to the next, that fails, you move on to the next. You can build on top of these things to try and get the most benefit from these treatments. And then surgery is also some options that I'm not going to go into too much detail about. It's not my area of expertise. Now, when I was trying to compress what could have been easily an hour talk into 20 minutes, I eliminated a slide accidentally that I meant to put back in here, and that is the important role of other modalities of treatment, such as the bracing and proper positioning in wheelchairs, proper equipment to help ambulation, that the physical therapists and occupational therapists are so important in working with, and that these therapies alone can frequently decrease your spasticity. So something as simple as having the proper wheelchair, being properly seated in the wheelchair can decrease your tone, because discomfort and putting joints in the wrong position can increase your spasticity. So all of these issues are very important as well, and I don't want to make light of them by simply moving on to the medications and the injections that I'm going to discuss. Now, the medications that are listed on the left side are the ones that I suspect are most frequently used. The medications on the right side are ones that are listed as medications that are used, but are ones that I personally don't have much experience with, although I've heard about them being used as well. Now, benzodiazepines, which are drugs like Valium, Ativan, and medications such as that, Xanax, in that class, most commonly what we use is Valium from the benzodiazepine class, and I have a reasonable amount of experience with this drug from cerebral palsy, not as much with transverse myelitis. Basically, it works on what's called the GABA system, gamma-aminobutyric acid, which is the body's natural chemical that helps prevent spasticity. There's long and short-acting kinds. Mostly we use the Valium. The mechanism of action is at the brainstem and spinal cord, and it works on the postsynaptic site where a nerve's attached to another nerve. It works on the site of the next nerve in the line, and it improves GABA's ability to work. Now, the adverse effects of Valium can be sedation, weakness, hypotension, GI symptoms, and the other various things listed, and sometimes intoxication is a possibility with those types of drugs, but generally, when you're using the drug appropriately for treatment of spasticity or other issues, intoxication is not really a problem. But dependency and withdrawal are possible. Oral baclofen is another drug that works on the GABA system, works on it slightly differently, which is a drug that is frequently used in patients that have spinal cord injuries. That drug also has adverse effects that are similar to Valium, which can be weakness, sedation, hypotonia. So some folks who maybe have good tone in their trunk, which allows them to sit upright, if you overtreat that, they end up getting a floppy trunk. They can't sit as well, or you lose the tone in their legs that help them walk. You can also get central effects on the brain, confusion, sedation, things like that. And it also may potentiate in folks who are taking medications for blood pressure. It may increase the effect of those medications, causing the blood pressure to go down too low. So make sure that you discuss these things with your physician if they're prescribing drugs like this. A very important concept about baclofen is that sudden withdrawal of the medication can cause seizures, hallucinations, and rebound spasticity. So if there are folks who are taking this medication and decide they don't like it, it's not working, don't just stop without consulting with your physician, because you need to taper down the dose so you don't get these potentially very dangerous withdrawal side effects. Tizanidine, another medication that's pretty new, that we're just starting to work, works a little bit differently than the previous two medications by blocking the way neurons work together to increase spasticity. So it gets pretty complicated, and I don't necessarily completely understand it myself, but basically it decreases the excitatory neurons, allowing decreased spasticity. And the clinical effects are reducing tone, spasm frequency, hyperreflexia, which again is the increased tendon reflexes, which can cause your legs bouncing, which can lead to problems, your arms as well. And it reportedly doesn't cause any decrease in strength, and it may decrease pain as well by a direct route, as opposed to just pain associated with spasms. With a drug like tizanidine, they suggest obtaining liver function tests before starting the medication, because it can cause changes in the liver, so we want to monitor that. And adverse effects such as drowsiness, dizziness, dry mouth, and hypotension once again. So these medications all have the possibility of leading to sleepiness and weakness and things like that, although some of those side effects wear off if the medication is used for longer term. Other oral medications I already listed, so I'll just move on. Now moving on to injections, peripheral blocks, the two that are most commonly used are phenol and botulinum toxin, Botox. There's also new brands coming out, MyoBlock. Now, I don't have any experience with phenol, just based on where I've trained. Not too many people are doing them, but have a lot of experience with Botox. Both of these injections are temporary and reversible. Not reversible, they sort of wear off on their own. And they can be used to treat focal problem areas. And what's nice about that is if you're treating somebody with an oral medication to decrease their overall spasticity, but they're still, the inside of your thighs are still a little tight, but you don't want to increase the oral medication, we can do injections in either the nerve to your inner thigh muscles, or we can inject those muscles. Or if your wrist's just too tight, we can inject those muscles as well. But you don't necessarily have to stop taking your oral medications with it. And frequently, people are on oral medications already when we do these types of injections. Phenol blocks cause a neurolysis, so it stops the nerve from working on the muscle. There are nerves that sort of lend themselves a little bit more to treating, such as the nerve that goes to the biceps muscle, which basically just does the muscle and not too much sensory innervation, and the obturator nerve, which does the inner thigh muscles, as I mentioned. There can be some adverse effects with this. I think the most common one is dysesthesias, which means funny sensation, burning, numbness, things like that, which Botox doesn't have a tendency to do. So why we mention the musculocutaneous nerve and the obturator nerve as sort of examples of good nerves to treat, because they have very small component of those nerves is a sensory nerve. They're mostly just to the muscles. But that is one of the complicating factors of phenol, is that you can get these unpleasant sensations associated with it. Now onto Botox. It's made from the Clostridium botulinum bacteria, which is how you get botulism. But injected in very small quantities into local muscles, you don't get botulism poisoning. Now what it does is it blocks the release of the chemicals from the nerve ending that go to the muscle, which increase your spasticity or the tone in the muscle. It's considered one of the most potent poisons known, with a lethal dose of about 1 to 2 micrograms. There's about 10 cases per year of botulism poisoning in the United States. This is basically just a picture of how it works. It gets taken up into the nerve ending, and it blocks the release of those chemicals that sort of end up just piling up at the end of the nerve. And then what they show here actually is nerve sprouts coming out, which originally is how they thought it wore off, is that these sprouts would come out and reinnervate the muscle. But they're finding that that's not really the case. What happens is basically it just gets broken down in the nerve axon ending, and once it gets broken down, then the nerve starts to work again. It's composed of proteins, some of which the body can develop antibodies to, which can lead to resistance to the injections. So we don't do the injections any more frequently than every 3 months to try and decrease the possibility of developing antibodies to it. So if you get a Botox injection and then another one and then another one a few months later and it stops working, that may be because you're developing antibodies, and there are tests for that. One of the exciting things about the newer types of botulism toxin coming out for injection are not necessarily that they work better or that they're less expensive, but they work a little bit differently. So if you develop antibodies to the one kind, we may be able to use the other kind with better efficacy. Now you can see how small the amount of Botox that we use. 1 unit is very, 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 very small, and only about 1/2,500th of the lethal human dose. And they did these studies on mice, and you've heard enough about studies to figure out what a unit was. And they're doing some more studies now with mice, testing how their fingers splay out or their toes splay out when doing the injections, and coming up with the units based on that. But I'm not going to go into too much more research detail. Now the disorders where Botox is being used to treat is a whole list of things. It was really designed more for cervical dystonia or neck spasms, and then spasms of the eye, but we're starting to use it for all sorts of other things. Probably what's most popularized now is using it for wrinkles around the forehead and the eye, but there's certainly more noble uses for it. Although I'm not necessarily opposed to using it for those things as well. Now, the patient selection for Botox is, again, along the same lines as using the oral medications. Does it interfere with function, comfort, or care, the spasticity? And then will focal tone reduction will not decrease the current level of function, so we don't want to make things worse just by decreasing your spasticity. And then, do you have fixed contractures? Now, what Botox can do is it won't treat the contractures, but there can be sort of an overlap between spasticity and contracture. Are you getting contracture because of spasticity, and will the Botox allow more ease in stretching that muscle to decrease developing the contracture, or will it allow ease with doing serial casting? Put a cast on, stretch it, take the cast off, stretch a little more. So we do that sort of hand in hand. And what it also can do is differentiate between just very severe spasticity and contracture. So if somebody's arm's really stuck or leg's really stuck in a position and we're not sure, we can do the Botox injection, and if it improves, okay, it was spasticity. If it doesn't, then we know it was contracture, and we can discuss other options. Adverse effects, there have been no anaphylactic reactions, those really severe reactions that cut off your airway and lead to serious problems. It can cause local weakness, which may affect surrounding muscles. In some of the little kids that we've treated with cerebral palsy, and we've done their inner thigh muscles, we have had a couple of complaints where that changed their bowel function and their bladder function, which may not be a bad thing, actually, because if you have a spastic bladder and we relax it a little bit, that may be okay. But it is something to be addressed and talked about. There has been some descriptions of generalized weakness or lethargy. I haven't really had that experience with the patients that we've treated. And there can be the development of tolerance with the antibodies that I discussed before. But about 80% of people report no adverse side effects from it. Intrathecal baclofen is sort of along the further continuum of these treatments, which is being used for the various disorders listed up there. Baclofen has a poor ability to cross that blood-brain barrier that's been discussed in previous lectures to get over into the central nervous system to treat. So by implanting the pump, it allows concentrations of baclofen to be delivered directly to the spine that achieve a 4-time higher level than the oral route. So whereas using oral baclofen you talk about milligrams, when using intrathecal baclofen you're talking about micrograms. So you can use a lot less drug. It doesn't get absorbed into the entire system as much as an oral drug, so you don't have the same kind of side effects from the oral drug, and you might be able to get significantly more improvements in treating spasticity with this type of a treatment. And it has proven efficacy with spinal cord injury and traumatic brain injury. The potential benefits are, of course, to decrease spasticity, prevent or decrease incidence of contractures, decrease pain associated with it, ease rehabilitation, improve mobility, improve quality of life. And, of course, the multidisciplinary health care team is involved in the care and goal setting, as well as the patient's decisions in these cares as well. Pharmacology, I'm not going to go into this too much. We can discuss that later at the breakout session if you'd like. I'm going over a little bit already. This is what the pump looks like when taken apart. It's got a reservoir where the medication is placed, and then it has a catheter that runs around to the spine where it's delivered. You fill the pump through a port. It's actually implanted underneath the skin, and you can change the dosing up to as many certain kinds of pumps. This one in particular, 10 different doses in a day. So if you're more spastic in the morning, you can increase the dose in the morning. If you're going to therapy at 2 o'clock every day, you can increase it around that time to try and make it easier for you to do your therapies. So it's really very sophisticated, and all you have to do is sort of wave this magic wand over the pump, and you program it that way, and it gives you an entire readout of the dosing schedules. And we have a few patients that we've been treating at Kennedy, one with transverse myelitis, who we're still ramping up the dose with to try and get improved benefits, and it's being tolerated very well. So the patient selection, of course, tends to be patients with more severe spasticity that have tended to not respond very well to oral medications. So when they get the pump, you try and get them off the oral medications, although you don't necessarily get them entirely off oral medications by putting the pump in. They say the age of 3, 4, or older, and at least 30 to 35 pounds. There is experience with children smaller than that, as young as 2 years old, 2.5 years old, that they've had pumps put in with good results. They do a preliminary trial dose where they put you in the hospital, they put a catheter into your spine, they give you a series of doses to get an idea of, one, whether or not it'll work, and two, what dose you might start the pump at, and then you get follow-up afterwards to try and change the doses. Now, the difficulty with the baclofen pump is, one, as a physician who works at Johns Hopkins and, of course, has trained at medical institutions, I just sort of assume or tend to assume that everybody has the same type of access to these sophisticated treatments and to physical therapists and neurologists and neurosurgeons and rehab doctors. So, oh yeah, we'll give you the pump, no problem. But if you live out in the middle of Texas where there's nothing going on and you're lucky to find a neurologist, these treatments are a little bit more complicated to try and implement because you may not be able to have the appropriate follow-up. So that's a consideration as well. Precautions and indications, you need to be aware of if you have kidney problems, renal function problems, which is certainly something that is described in patients with spinal cord injuries that will be gone into further today in subsequent lectures. Pregnancy or breastfeeding, history of autonomic dysreflexia, which is the sympathetic nervous system being injured at higher levels of spinal cord injury. That can, if it decreases some of the noxious stimuli or the painful stimuli and you don't notice it as much, that can lead to a problem with autonomic dysreflexia. Use of depressants or alcohol along with it, or any of the other medications that I was discussing, or a history of uncontrolled seizures. And that's along the same lines of if the pump malfunctions and all of a sudden you stop the baclofen into the spine and you have a history of seizure disorder, that can increase the risk of having seizures. The refill interval is about every 6 to 12 weeks. The baclofen itself is stable in the pump for about 30 days, for about 90 days rather, so you come in at least every 3 months for a refill. You can actually set the alarm in the pump to go off when you get down to about 2 cc's or 2 milliliters in the pump, and there's this very, very low volume beep that you can hear. But we usually refill the pump about a week before you get to the alarm date. Side effects, as listed, hypotonia, somnolence, nausea, vomiting, headaches, and dizziness, although since it's delivered directly into the spine and not taken orally and not absorbed into the entire system, these side effects tend to be less frequent. The risks, it's surgery. You're putting a catheter in the spine, there's risks of infections, there's risks of seizures if the pump malfunctions, as I mentioned, there's overdose potential, which can lead to respiratory depression, consciousness, coma, or even death, although these are infrequent and uncommon. And even routine use can lead to increased risk of scoliosis if you lose the tone along the spinal column and those muscles become more flaccid, then the spine can collapse down. And since it's only been used for the last few years and my experience with it is only about a year old, I haven't seen those complications yet. And that's about it. If there are questions or you want more information about these medications and treatments, there are the breakout sessions.